Hello and welcome to HealthTech Hour on UK Health Radio. My name is Steve Roest, and each week we bring you the best news, views and interviews with the leaders, founders and clinicians who are driving the health tech revolution in the UK and beyond. I am a CEO and founder of a health tech company myself, and I'm passionate about the people and companies who are changing the world. Before I introduce this week's guest, I'd like to remind all the listeners to follow us on social media. It's at HealthTech Hour. And please also follow UK Health Radio, which is at UK Health Radio, to stay on top of all of the great content coming up on the station. So on to today's guest, Elliott Engers, the CEO and founder of Infinity Health. Elliott started his career in the post-room of Virgin Records, but has come quite a long way since then. Infinity Health are actually the perfect example of why I love doing this show. So their area of focus is digital task management, which on the face of it doesn't necessarily sound all that exciting. But, and I think it's a big but, if you consider within the NHS that 60% of all adverse events, i.e. basically something that goes wrong, that's 60% of all things that go wrong in a hospital happen because of poor task management. And miscommunication in clinical settings costs the UK taxpayer over £1 billion a year. You can see that the problem that Infinity and Elliott are trying to tackle is massive. So in just one department of one hospital, Infinity's platform of digital task management saved over 10,000 hours of staff time in a year. That's just one department in one hospital in 1 year. Infinity have also adapted their platform to help the NHS scale COVID-19 self-testing using lateral flow tests within NHS staff. And Elliott has also been accepted onto the NHS Innovation Accelerator, and he's one of only 12 people this year whose contribution to the NHS has been so valuable that they've been invited to join this prestigious program. So there's a lot to get into onto today's show. I'm really fascinated by solutions like Infinity because it simplifies something that is actually complex, and it does it in a very efficient way. So Elliott, how are you?
I'm very good, thank you, Steve. Thanks for having me.
Good to have you on. How are things during lockdown? I kind of ask everyone, what's the kind of the mood in the camp? How's the team been? How's the company been?
We've been phenomenally busy, which has meant that we've been very distracted from a lot of the things. We've been quite successful in sort of working remotely. We use tons of tools like task management tools, project planning tools. They all work remotely. Teams, Slack, Zoom. We can have a conversation remotely. But I think the year's starting to take its toll. I think everybody's looking to kind of recharge a little bit. Everybody's looking for this to be the beginning of the end. It certainly feels that way. So there's optimism, but it's been a very long year.
It really has. It really, really has. So as regular listeners will know, the show's in 3 parts. So the first part is an origins, sort of story. And then the middle part is all of the great things that you and Infinity are doing right now to change the world. And then the final part is, what's the future for Infinity, and, kicking around a couple of topics of the day, maybe COVID related, maybe not COVID related, who knows? So to start with, let's go back to the post room at Virgin Records. At what point did they let you leave out of the room?
Oh, well, that was interesting. So I started off life in the post room. So I was doing music at university. It was a classic case of sort of like dropping out of university, going and getting a real job. Ended up in the post room at 18 at Virgin Records, which was amazing. I was there for like 3 months, I think.
Okay.
It's the sort of being in the guts of a business like that kind of gives you access to sort of like get your face around, sort of understand how things work. And then a job came up internally and I went for it in what was called college marketing. So I basically started marketing to my peers. I was marketing to universities at the time, music that I loved. So it was amazing for a few years, and sort of started to work my way up in UK marketing, sort of understanding how to sort of like manage a marketing budget, sort of like managing expectations, putting a plan together, executing well, and then learning from what went well. And then I kind of watched an entire industry get completely disrupted by technology.
I think that's putting it mildly.
A learning experience. So that was definitely something that we learned from. It's like understanding that the relationship people have with technology can be quite profound and quite important, and it can transform the way they behave in meaningful ways. It really did inform a lot of sort of what's core to our principles now about how technology can be applied effectively to be better for everybody in a quantifiable way.
Okay, well, we can get into that. We can get into that during the show, because I think that's a really interesting area. At what point did you kind of transition from, you know, the music business into, I don't know whether it was, you know, whether you got into health tech via kind of a stop off on entrepreneurialism somewhere, or sort of, you know, what was that journey like?
Haphazard, I would say. So I in search of something that made me feel like I was doing something meaningful. So the music industry was about to go through a dramatic change with the launch of things like iTunes and selling music digitally. And one of the companies I was working for wasn't being as progressive as perhaps it could have been. So it wasn't a place I wanted to be. So I left.
Was it a label, or what was it?
Yeah, Virgin Records. So like we had it was an amazing place to be. So it was like an independent that like kind of played in the same waters as the big guys, as the Sonys and the EMIs of this world. And so it had all of the sort of like passion of an independent label, but all of the money of Spice Girls. So we had, yeah. So it was a fun place to be, but it wasn't about to sort of like move quickly and be very agile in the face of things like iTunes. So I handed my notice in. I was like, I'm going to go and do something else, and sort of took some technical skills into building technical experiences for media companies. So we were building like websites for like West End shows and things like that, because we had a lot of media contacts out of them. So we kind of leveraged that, and it got to the point where we were getting pretty good at building things for other people and getting pretty frustrated by sort of like client requirements. But we thought we could build something. We could build our own IP. We could build something, our own product, our own application. And my co-founder was a doctor at Stammer Orthopedic, and he had been sort of for years going, look at how terrible this is when I go into work. Look at how this works. Look at what I have to do. Look at how I have to do this really important thing in my day to day, and the technology I don't have. And it was our 10 years of talking that we kind of, that was the transition point where we thought we'd had the technical skills. We thought we had the experience to kind of really go for something, and we thought we'd found a problem that we were ideally suited to solve.
Wow. Okay. So did you, in that period of time, it was you and your current co-founder that sort of funded almost like a development agency prior to Infinity? Is that how it sort of went?
Yeah, correct. We kind of like we were trying to work out what we could do in technology that was meaningful. So we had a web development agency and a web application agency. We were doing some marketing. We did some stuff ourselves. I was a music manager for one time. I worked in an art gallery. Like really for like 5 years, I was like, I need to find what I want to apply myself to early on in my 20s. And then, and we found it, and we've been working on it for what feels like a very long time. Yeah.
Cool. And he was a doctor the whole time, your co-founder?
Still is.
Oh, he still is?
Yeah,
okay.
Still is.
Right.
Never actually sort of like worked full time in the business. Was just sort of like a co-founder in that sense.
So when your co-founder told you about this problem, you said you've been hearing about it over 10 years. So what was your first reaction? Because I know when you told me the story of the business and when I read about it on the website, it's sort of like, I was like, well, that's crazy that happens or continues to happen that way. So, I mean, you know, I know that we haven't quite gone into what the problem was.
Yeah. So I think we've got some bandwidth issues, but so sorry to speak over you.
No, go on.
Absolutely. So that was my reaction too, is that like, how can this still be a problem? How has this not got a solution? So let's state the problem. So the problem is so he stated at the beginning, was that 60% of the time that anything goes wrong in a hospital is because we don't know what we're doing.
Right.
Like we're not and it's that someone hasn't updated that this now needs to be done, or handed that piece of information over, or they've made a mistake, or they've put it on the wrong line of an Excel spreadsheet. Like when you look at hospital adverse events, 60% of the time, poor communication at the point of handover is a contributing factor. And that seems crazy. So that's once you start to unpick it. And then when Adam, my co-founder, explained the problem to me, so it was very, very late on the weekend. And we were talking about the kinds of problems that we could go after. Like, what is the kind of thing that a small company in healthcare can actually do something in? Like, where can you have a real impact? And it felt like, so he just he stood up, pulled out from his two back pockets, two separate pieces of paper, because he was on two different surgical firms at the time with two different surgical consultants as bosses with two different handover lists that were effectively the same thing, right? So it's an Excel or a Word document with a table in it with effectively 3 columns or a few more, depending on how sophisticated you are as a team. But it's typically who are our patients that we care about, why are they here, and what are we doing to them right now?
Okay.
What needs to be done? What are the priorities? Who's doing it? And then that gets updated beginning and end of every shift, gets printed out, handed over to the next person. And it's 4 o'clock in the morning, and Adam had 2 handover sheets. A, what are you doing with 2 handover sheets on you? Yeah. Where's the on-call doctor? What's he doing? He didn't turn up on time. I stayed an hour, so I had to leave. I handed over to him in the car on the way home.
Wow.
Right? Yeah, and this is routine. This is and he's on the phone. He'd taken 2 or 3 phone calls that night because people needed information, and I was like, I was having the reaction you were having. I was like, this can't be this bad everywhere. This can't. Yeah. This has to be an anomaly. So we started looking. So we went to the Royal Free. We went to UCH. We started talking internationally. And that last mile of healthcare genuinely is incredibly analog still. Like, even if you've got a health record system, that who's doing what when is being written on a whiteboard or a magnetic icon that's only discernible to the people on that ward in that particular moment in time will understand what it is. Or it's being added to a Word document, or it's being bleeped via a pager to someone, or it's a phone call or an in-person meeting. There's very little good technology at that moment that helps staff, and that's what we thought we could do, is we could build something there.
And that, obviously, that's the kernel of an idea. You found a problem, you thought you could come up with a solution. How did you go and do the initial feasibility of it? Because obviously, particularly with the NHS, just because you've had an idea doesn't necessarily mean that your idea is what they want, or even if you're pretty confident it's a great idea, you're still a long way away from actually getting that implemented. And because you're working with the NHS is basically the gatekeeper. It's a bit different whereas a private, if you're doing something privately, then you can just sort of go live, so to speak, at your choosing. So how did you move from that sort of, position to actually starting something?
Validate it, assume you're wrong, question every assumption. Spent a lot of time doing that. So trying to humble yourself a little bit and treat it more scientifically. So the business that we have, do we have a proposition that people think are interesting? Go and test it. So we went to, at the time it wasn't Innovate UK, it was the Technology Strategy Board. When we applied, they were going through a rebrand at the time, and we applied for a proof of concept. We said, look, we want to build a handover app that's mobile first, that's designed, that will plug into hospital systems, that will help staff at the beginnings and ends of shifts, make sure that there's high quality information being handed over and things don't get missed. Let's test that assumption. And then you put together a grant application, and we were successful. And we were like, that's a pretty good test. That people that know what they're talking to have reviewed this in duplicate and triplicate, and they think that the plan we have and the team we're assembling and is applicable. But be super careful, because that was So that we took that as the market really, really needs this.
Yeah.
And as it turned out, what we think the market needs, based on sort of the traction we're getting now, is not quite that. And that's come about because we kind of continued to question whether or not we're being useful, we're doing the right thing. Are we focused on the right problem right now? Because it's changing all the time, right? I mean, like, right, you and I have been doing tons of work on lateral flow testing,
Yeah.
right?
Yeah.
For different reasons, but both of us have been involved because that's what was important right now. That's the thing that was the challenge for frontline staff. So I think that's what we've been doing, is kind of just keep listening and keep testing your assumptions.
And how did you, because I'm always interested with like startup businesses like we are and like you are, you're a bit further ahead than we are, but with the NHS for sure. How do you get that? How did you guys get that first real world kind of pilot or trial in the NHS or with an NHS entity where someone said, no, actually, we think that what you're doing is actually quite interesting. We'll give this a punt.
I think with like any success you have in improving or changing healthcare, it's never one thing coming together, right? So it's always sort of 3 or 4 things converging at just the right moment. Timing is key. For our perfect storm was we had built enough product. We had a tool that was working and was ready to be used in clinical practice and to be tested. So that was important, having a proper demonstrable MVP, whatever you want to call it. We had built enough team by that point that people felt confident that we had the right people that could do it. We were on Digital Health London Accelerator, was probably the last piece of the puzzle that we needed. And that all converged on, there's someone called Sonia Patel. She's now CIO of NHSX. At the time, she was CIO of London Northwest University Healthcare, very large trust with three hospitals in Northwest London. So what Sonia did was she said, look, we have to be open to what these smaller companies are saying. They've got big ideas with big ambitions, can solve big problems. We need to give them some time. We need to listen to them. And they had something called the Digital Den. And they would invite companies in to pitch in similar ways to the way that startups pitch to investors. But pitch your proposition to this innovation panel that constituted of Sonia, digital leads, IG leads, finance leads, operational clinical leads. And they would encourage people within the trust as well to come, so like staff to come and pitch ideas as well. And we were one of those companies that got invited in because we were on Digital Health London Accelerator. And she listened to us and she said, I love it, let's do it. And so she allowed us to pilot our handover app, which we got some like amazing buy-in and really great feedback, and we learned tons from. And then it was Sonia that said to us, look, this is great. And like, I'm a believer, but the current problem we have and that we have the capacity to solve and the drive to solve is this problem over in the emergency department with waiting times. You're a task management solution. Do you want to go and have a look at it? Right. And we said, yes, thank you very much. And we did. And I think, and everyone in our business was like, well, she's pointing you towards a problem that isn't necessarily our core business and we need to stay focused. And I think what you need to stay focused on is solving your customer's problem. And you need people like Sonia Patel that can like give a company a go, spot an opportunity to do something. And hopefully we've, returned that favor a little bit, but it's that's what it takes. It takes a champion.
Okay. And at what point did this become a kind of a mission for you and your co-founder? Or was it always a mission? Or was, when did it move from being like, oh, that's a super interesting opportunity into, oh my goodness, this is my mission to help improve efficiency in hospitals, to help, improve patient care?
There was a point when, during very early prototyping stages, where I was looking at it and I was thinking, yeah, this is exactly the kind of problem that a startup can solve. There was this, we realized that this was about a big EHR probably doesn't have the the capacity to be looking at the problem in the amount of detail that we were looking at it.
Mm.
And we were discovering the really important things that allow you to build really effective products. And it was in those early days, those early prototyping days, where I was like, we've got this. Like, we really can build something of value. Frontline staff unanimously bought into it. They
Right.
like the minute they saw what we were trying to do and the way we were trying to do it, everybody was there. So it just felt to me like, oh, this is just going to be a matter of time before we convince the powers that be that their frontline staff need this, want this, and it's going to make things better.
Okay.
That was probably a bit naive, but that's what gave me the drive. Seeing that it would work. So, like, just knowing that we've got this, like, it makes a difference. And there's been times along the way where, like, you've seen some data come in, and that's really validated something that you thought was true. Those moments, it really reinforces the mission as well, I find.
Yeah, I can imagine. And so what were some of those, you said that you were looking into the prototype and you saw some details that you were looking at and you realized, like, oh my goodness, we've got this. What was that kind of light bulb moment, or what were those details?
So we would do things like UX testing. So we would give like a clickable prototype on, say, a tablet or a smartphone or a mouse and keyboard. So we try and put people in front of something that we think is going to help them with no instruction whatsoever.
Okay.
And we would just ask them to explain back to us what they're seeing and what they think the purpose is and what would happen if they click this thing. All right. Okay. And it was amazing, like, just seeing people kind of go, okay, so this is a list of my patients. This is where, like, I imagine this is like entirely up to date. So, and it's got all the information I need there. And if I click this, oh, I get a list of all the tasks associated with them. So these are all things, and then they could discern everything. And I'm not suggesting that we've built something that's 100% intuitive, but on the whole, our UX testing would go incredibly well, to the point where we could then say, okay, we want you to perform this user journey. We want you to be able to sign in, select a patient, add a task to them, and then mark that task as completed. And someone without any instruction whatsoever, 80% of the time was completing that with no, and we thought, okay, hold on, this is something that might be able to be embedded without any sort of like 16 hours worth of training, right. And all of that cost. It's send them a video, their colleagues will help onboard them when they turn up for a handover meeting. And that was true. So during the pilot, we tried that. We said, anyone new that starts throughout the pilot, you train them before the handover meeting. Let's see if that works. And it works. So like they were able to onboard them in the 3 minutes before a handover meeting, sort of invite them into their team, give them access under controlled IG rules. And then this person was able to create and update tasks as they went throughout their shifts, sharing that information in real time with their team. No problem.
That's awesome.
Those are the moments.
Yeah, I mean, that's got to be pretty exciting when that happens.
Mm-hmm.
Yeah.
Going live, those moments are pretty amazing when there's no stopping it now. Like, you turn this thing on and suddenly 500 people are relying on this to work. Yeah. And if this doesn't work, this is something that we do. So, like, requesting a porter in an emergency department is something that you do 350 times a day as a department.
Right.
Get that wrong.
Yeah.
So, like, you can have a very bad day in your ED. Yeah. But when it works, it's incredibly gratifying to see it all come together. And it's not just your success, it's like the success of such a huge team. Yeah. So we just get to be the tech on the end of it.
That's good. That's awesome. So let's turn to the actual product now, and maybe you can kind of, like, for the listeners, just walk through what it does more and why it matters to ultimately to a patient. Why does it make a difference? Because, I think all the sort of technical systems, it makes sense why hospital administrators care and why heads of department care, but, like, why does that actually matter to patients?
Okay, so probably best to just, I'll pick one tiny example, which I think exemplifies everything you've asked me to say. So let's take the example of what's the current experience as a patient in emergency department. So you go and see, you've had a road traffic accident, you've gone to the ED, you think they've suspected that you've broken your leg, you need to have a scan, right? So you're sitting in a bay, in ED, and your doctor decides, right, I'm going to send you for a radiological scan. The current process in a lot of our emergency departments in the UK, to demystify it, is that doctor will then leave you in bay 2 and walk towards a clipboard on the other side of the department somewhere, which can be, these departments are getting pretty big these days, but that could be a 2 or 3 minute walk. And along the way, they're going to get accosted for questions and answers for everything that's going on in the ED. They get to that clipboard and then they'll write down, my patient in bay 2 needs to go to ED X-ray. And so you'll get bay 2 to ED X-ray on a scribbled down on a piece of paper in doctor's scrawl.
Yeah.
No offense to all our doctor users. And then they come back to the patient. And then what might have happened, by the way, is like while they're waiting for that porter, someone's saying, are you using bay 2? We've got like another road traffic accident, we need to get in there. No problem, I'll move my patient out into the hallway. You stay here, don't worry. You'll be on your way to X-ray soon. Right. And then 15, 20 minutes later, a porter might turn up to bay 2, is looking for the patient to move. They're like, well, you're not moving this patient. Right. Well, then where's my patient that I need to take to X-ray? I don't know. Like, I don't know who was here before. Right. And because they don't keep a log of who was in that bay for those few minutes that they were being examined. And so the porter will then be dejected, go back to their supervisor saying, I couldn't find the patient. I didn't know who requested it. We don't know the name of the patient. They're not in bay 2. What do I do? And the porter supervisor will just scribble a note down going, problem with this bay 2 to ED X-ray job. And sort of half an hour later, the doctor will come back, see their patient in the hallway, be rightly annoyed about that, because it's really important this person needs to get to X-ray. Meanwhile, you've been sat there in the hallway wondering what's been going on. Your job's been cancelled and now there are no porters and now there's another reason why you're not there. And it's taken you an hour to get to X-ray, which is like 15 meters over there, you know? That exemplifies that there are thousands of processes like that are high volume, mission critical, and when they go wrong, you get patients lined up in corridors or patients staying an extra day in hospital, which is a terrible experience as a patient. You feel very much like the system around you is just behaving in a really inefficient, non-joined up way, and that's because it is. It's the truth. Yeah, it's hard to join these things up. So with Infinity, so what does Infinity do? So we're a task management solution. So we can basically attach tasks. So a task is an actionable thing, something that we need to get done. So it typically has a title and a description and a start and end time. It might be tagged and categorized. So this is urgent, or this is a nursing task. And then it can be assigned. So Elliott's doing this, or Steve's doing this, or Elliott and Steve are doing this, right? And then it can have a status. What, like, is it requested? Is it pending? Is it in progress? Is it completed? Has it been cancelled? So they can be in these different states. Okay. And Infinity is a way of attaching these tasks, which are these really useful ways of coordinating activity, to patients, and then prioritizing them. And we've over the years, we've now gone quite a bit further. So that probably is the simple explanation. And behind the scenes, we're able to do things like, okay, so if a patient gets admitted into the hospital and they're of this age and they've got this past medical history, perhaps we want to do these 3 tasks first, or any inpatient we should be doing a VTE assessment for. So we've got automation where we can do automation.
So does that mean you're kind of like, so when someone comes in to a department, or I guess, well, their first point of contact or the point of contact with Infinity, does someone upload them, so to speak, into the system? They add them to the, space, or how does that sort of work?
We do that through integration, so that no one would tolerate having to enter that information twice. So that information's collected. So that's another frustration as a patient, is that you get asked for the same information over and over again. And the reason you're asked, so the controversial thing that I might say is they'll tell you that this is actually really useful because it means that they can double check and that they're validating this information. But the truth is, like, you're being asked this over and over again because the integration of healthcare data is poor. Right.
Okay.
It's the truth. The state of apps don't talk to each other the way they should do.
Right.
So people don't know. When you get to the ward, the nurse doesn't know your name, so they're going to take a past medical history. That hasn't been brought over from a previous encounter that you had there just 3 weeks ago. You know,
Okay.
that stuff doesn't happen. So what we do is we plug in. So
yeah,
sorry.
go on. No, go on.
I was just going to say that, so we don't ask, where we can, we don't ask people to do things in duplicate. So our goal is to reduce steps. So so someone gets admitted to a hospital, we get told about it through something called ADT feeds, admission, discharge, and transfer messages.
Okay.
So every time someone gets admitted, Infinity gets told about it through a secure tunnel. We'll then synchronize that patient on both sides, so they're admitted in Infinity, and when they get moved, we'll move them in Infinity, and when they get discharged, we'll then discharge them in Infinity, so we can keep the patient in sync.
Perfect. And that means that no one has to do any manual data entry or anything like that, which is, so in theory, when everyone working in that ward or that department sees all of the patients automatically and then can immediately start assigning tasks or you know, doing whatever they need to do within Infinity.
Yeah, when Infinity's plugged in to a hospital, so yeah, it's quite grown-up integration. So once we've established a secure connection, what we can do is replicate in Infinity all the wards, all the clinical areas that might exist, all of the teams in Infinity as in the form of different lists. So you could go into the Ward 1 list, or you could go into physiotherapy. And then every time someone is admitted to Ward 1, they just pop up on the list. And when they get discharged, they just disappear. Sort of all happens in real time, just like blinking lights.
Okay.
And then what that means is you can now just attach tasks to all these people, and they're effectively linked across the health record. So you can use it for really great audit data and perioperative data.
Right, which previously didn't exist because no one was, is it fair that no one was really tracking a patient's end-to-end experience on a patient level, on an individual level? You weren't able to do that. Is that correct?
I think it would be unfair to say that no one was doing it, because there's a lot of people that were, and they were doing that, like they were putting in huge amounts of effort to do that because they understand how important that is. But it wasn't happening it doesn't happen en masse. All of that, like, what are we doing? Like the really important thing will get written back into the health record.
Right.
But a lot of what's happening while you're admitted to a hospital or you're within the care of a community team is just done and it's documented in informal ways, and that is not linked to your health records. So, but you would, all of the really important clinical things would have been written back, but it's just a very manual process to do that. And you're now doing that in duplicate from your Excel document back into the health record.
And how much do you think and it might be both, by the way, but how much of Infinity's mission or your mission is around, you know, managing tasks and improving or reducing risk associated with handovers versus, you know, overall efficiencies throughout the system, which are not necessarily the same goal?
So I would argue that they are.
Okay.
I used to argue that they weren't, but a health economist convinced me that they were.
Okay.
That they're the same. They're the same thing. So if we deal in the efficiency metric that we typically deal in, which is time, time being money, in the Scrooge McDuck vernacular. But so if you could give back, so if you think of time purely as the less time we spend on something, the less it costs us. Great. That's the sort of very blunt way of looking at it. And there's terms like cash releasing benefits and in-year cash releasing benefits and things like that. So if you can demonstrate you're saving enough time that you could actually free up some resource, and then you actually free up some resource, you've actually reduced the cost of something. That's the gold standard of sort of like efficiency gains. But time means so much more, right? If you can give time back to staff, you're going to get better retention of staff. You're going to get a lot less burnout. Right? And we should be talking about burnout in the NHS right now, given the daunting task of the backlog that's bearing down on them, having gone through the year that they've gone through. You know, it's understandable the amount of pressure these people are under. If you can just give them back some time, suddenly they're able to care for their patients better. They're able to care about themselves a little bit better.
Right.
So I think we kind of deal in time, giving time back, and they're the same thing. So like if you can, the more time you give people back, the more the better experience the staff members will have, the better the experience patients will have, the better care people will be given, the better outcomes we'd have, and the better cost. 100%.
Wow. I mean, when you put it like that, I think I kind of agree with you as well. When you put it like that, that kind of time is the most critical thing that you guys deliver. So is it more, have you sort of started to track, or do you track overall the time savings that Infinity delivers? I know that we mentioned at the start of the show the 10,000 hours in a year in just one department with which related to the porter issue, which you already explained. But have you got any other kind of demonstrations or data around the savings that Infinity delivers?
So we've started to do that. We're trying to, well, I say started, we've been doing this for years, but we've starting to do something that's a bit broader in terms of evidence generation that can demonstrate that sort of on average, once Infinity is used, it could save you this much time if you're a staff member predominantly doing these activities. And if you're in this role and you're this staff grade and you're predominantly doing these activities, Infinity will typically save you this much time. That's the mission that we're working on. We as we lead up to that, it's just building a portfolio of case studies and evidence and evaluations and proving to ourselves that the solution we've built works.
Yeah.
And then trying somehow to be very careful about how can you extrapolate the benefit we got over here under these very specific circumstances. How much of that benefit can we reasonably expect would work at this organization 200 miles away, with completely different patients, completely different layout, completely different working practices? There is going to be some variation. Our general view is, though, we just need to be able to demonstrate every single time you give us a legacy run process, paper, verbal, pager, Excel document, we can improve it in all of these ways. We can make it safer, we can make it more reliable, we can make it more efficient, we can make staff happier, and we can make patients happier in every case. And I think if we just continue to do that, people will believe it. Yeah,
happier and healthier, right? If like 60% of all adverse events that happen in hospital are related to, a lack of good handover process, task management, then it relates back to patient health. Because it's actually improving or reducing the risk of an adverse event.
Yep, that's the way we see it.
Yeah, well, no, I agree with you. And what else? When you properly started the company, what else was doing this role in the NHS in any capacity? Was there some solution or a number of solutions that were similar or slightly different, or what was? Because obviously, as you said, your co-founder had been talking about this problem for 10 years before you guys did anything about it. So I'm assuming it was not an unknown problem, right? So what if anything had been done or discussed or, thought about?
Yeah, it's not like we discovered this problem. This is a 30-year sort of poorly hidden secret about when you peek behind the curtain of what goes on in a hospital. So this is quite well understood. So what else was going on in the space? So there was a belief, I think, during the National Programme for IT that electronic health record systems were going to solve all ills. And perhaps people weren't thinking specifically, like in the vernacular we use, like task management, workflow, patient flow, those sorts of things at that moment. But they were certainly thinking we're going to digitize all information, and therefore we're going to have digitized all processes. And the truth is, you haven't. What you've done is maybe you have created digital aspects of processes, but they're probably detrimental to the process because they've not been designed to be beneficial to the process. What we do is we assume the digital health record is a solved problem. Organizations can buy databases, right? We can store information in tables. And I think we need to stop patting ourselves on the back that we've managed to do that
Yeah.
and start do the slightly harder things, which is like, right, now that we've got this data stored in a different way, how can we change our behaviors around that?
Yeah.
And we're the sort of technology that kind of comes in and says, right, we're going to assume that data exists. So what we're going to do is we're going to pop up on your list and we're going to say, hey, you might want to consider doing this thing at this time because you happen to be here and you are in this role and this patient is here and they need this thing doing. So you might want to consider doing this.
Your system, or it either is, or that's where you're going, which is almost like dynamic role task assignment, if you like. So someone might be moving, someone relevant to a patient might be in the vicinity of that patient, and there might be a task floating around for that patient, and your system could kind of match those up. Is that what you're sort of saying?
Yeah, so it's more symbiotic at the moment than that. So we, for a few good reasons, like the main reason is that we're not confident enough yet to say this person should be doing this thing now. Right. The second reason is the minute you start doing that, there are some tricky regulatory issues.
Yeah, because you're puts you in a tricky position. Also, like that's what doctors are trained for, right? Kind of, almost.
Well, exactly, and it's the antithesis of what we set out to do, which is that technology can help here. It's not trying to take over. In fact, it's trying to do the stuff that you hate doing as a frontline member of staff, I would imagine, which is all of the unnecessary documenting and duplication, the unnecessary phone calls, updating someone. Why do I have to update 3 people when I could have just entered it here once and that information is shared instantly with everybody? And why am I chasing this person when it should be here? It should be updated in my app if it gets updated elsewhere. So I kind of take that view on it, if I'm honest.
No, I think that makes sense, because I think otherwise you end up, as you said, I mean, it's a little bit like, not same, but different, where we've been with PocDoc and our sort of cardiovascular tests and diabetes tests and things like that. It's sort of, we're not looking to replace the clinician aspect of it in any way. We're trying to create a very easy, immediate, quick test that someone can do with their smartphone, either in a clinic or in the home or in the community, to give people access, to give people, individuals, and also clinicians and health organizations access to that data, biological data, so that they can make treatment decisions more quickly, so people can get better more quickly. What we're not trying to do is to sort of create some robot doctor who will then, provide, like, that's not really what we want to sort of get into at all. So yeah, I completely agree with you on that front.
Can I ask you a question?
Yeah, sure, please.
So testing then. So the kind of testing we're doing at the moment, do you think it's going to be around for a while? You mean
the COVID testing? Is that what you mean? Lateral flow?
Yeah. Do we think like lateral flow and LAMP testing is going to be here for a while?
I mean, you mean, well, I think lateral flow has been around for years and years. It's not a new technology. Pregnancy tests are based on lateral flow tech. So our tech is lateral flow. So it's a kind of a broad concept. It's, rapid testing, if you like, or point of care testing uses lateral flow, has done for a really, really long time, for lots of like really, really good reasons. I think it's now become kind of like part of the day-to-day vocabulary, which it wasn't, like 12 months ago. And people are well aware of it. I think, we believe that the point of care testing was not being used as much as it could be, being used within the healthcare system. That there's a reliance on venous, pipe out of the arm off to a lab, the existing pathology lab process. This is not related to COVID. This is more in general, and that process itself normally requires someone to go to the doctors twice, one to get the sample taken, then they go back to get the results read to them. That could be a week or 2 afterwards. There's a delay. There's obviously a cost to the healthcare system, because you need to have someone who's trained enough to take blood out of an arm, which is a higher band, where actually if you can move these things onto a more finger prick basis, you can sort of democratize the testing process, have more people involved, scale it up more cheaply, and the results are available right there and then. So that's how we sort of approached it. And I think as a result of the pandemic, what you're going to see, or what was already being seen, is the need to move services out of a clinical setting and into a community setting or a home setting. That is not going to change anytime soon. That was something that should have been happening faster than it was, and now this has sort of accelerated it. And if you're going to move testing out of the clinic into homes, then you need a digital platform to be able to capture those results in real time and share them back with the electronic health record, with the GP's back end, wherever that data is ultimately going to go into your digital medical record. That has to happen in real time and be super usable and not require a minimal of input and sort of expertise from whoever's doing the testing, whether it's an individual testing themselves or whether it's a healthcare professional that's doing that in a sort of a non-clinical setting. But I believe that this, that's the way that this has to go. And I know that there's already trials up and running, with various things about how to do certain checkups remotely or certain, tests remotely. And so I think that type of concept, point of care testing, digitally enabled point of care testing, rapid testing, is here to stay and will grow across all disease areas where it's relevant. In terms of whether or not, COVID testing will stay around for a while, I guess. I hope that it kind of goes away at some point. I'm sure that we all do. I don't see that PCR testing and LAMP testing, that's almost a replication of the existing lab process. So for us, or the way we think about it, there's sort of rapid point of care, and then there's anything that has to go off and be processed in a lab. Now the issue, I think, what's happened, what you've seen, there are PCR testing labs that can turn things around really, really quickly. I don't know if that kind of capacity is then going to get switched on to all of the other disease areas. I think it won't, but that's kind of my thought. I don't know what you think.
There's no chance that there's going to be the funding to do that. And my view is that we're going to have, testing is being ramped up. We understand now as a society, higher volume of tests and higher quality of tests, sure, but higher volume of tests, it can be enormously valuable. And I'm certainly not the expert when it comes to sort of rapid testing for COVID-19. We just understood that it's not a perfect test, but it's the only thing we can do. So if you do enough of it, you're going to discover some asymptomatic cases that you wouldn't have known about. That's great, as long as you don't rely on it as the be all and end all test. Doing as much lateral flow testing as you possibly can is a beneficial thing. So we thought our goal here is we need to make it easy. So if this is going to be done sort of twice a week by frontline staff, we just put ourselves in the shoes of the frontline staff who's now being asked to fill out this really long form, giving their first line of address, their postcode, their phone number and their email address every time they submitted a test result. We were okay, that's something we can smooth out as high volume admin process that could just be improved by a bit of task management.
Yeah, no, and we on the COVID testing side of things, we felt exactly the same way, which was if you're going to, we very early on recognized that rapid testing was going to happen, but the only way that really it made sense for it to happen would be if you had a digital platform behind it to record the results, log the results, take any additional information that you need to. Our system captures a photo of the test because we were more focused on workplaces who wanted that to be then sort of embedded in a certificate or some form that way. But yeah, I completely agree with you. I think that this idea that if you don't have a digital system, digital platform to capture those results, to digitize those results, the value of the test goes in the bin when the test is done. Which if you're talking about major public health issues, then that's really not what you want. That's the opposite of what you want, really. So yeah, and and if given the, if people are talking about using rapid tests for opening up travel and opening up events and things like that, if you're going to use it as a step between, an access kind of concept, then you need some sort of validation system to capture that information, to issue a certificate, but there also to be traceability and an audit trail back to, what was the test? Who did the test? When was the test done? Is there a copy? Is there a photo of the test? Because even to your point, yes, there are not only are there false positives, false negatives, there's also user error. you know, when people are kind of, you know, they see a line, but there's no line, and you need to go back and check whether there was a line or not. Things like that. I mean, healthcare professionals in the NHS, one assumes that they are of a certain, you know, capability to be able to discern that, but not everyone will be, you know.
Yeah, not everybody on the front line, the patient-facing staff, is a healthcare professional in the sense that they've got medical training. So assuming that everybody's an expert at doing self-testing, it's all alien to a lot of us, I think.
Yeah, I mean, I think it very, look, the whole pandemic has had a huge impact on the healthcare system across the board, obviously, you know, and there's been technologies which, you know, I mean, our clinical advisors have sort of, they like to say that there's been more change in the last 12 months than there has been in the last 10 years, you know, in terms of integration and adoption of digital technologies. I think the rapid testing conceptually, you know, when we started our company PocDoc, our technology is based on, you prick your finger, you take a small droplet of blood, and it goes onto the test chip, and you take a photo of the test after, and it can calibrate the value of the biomarkers based on the color change of these things. So the first test is lipids, and working on a diabetes one, and there's a few more disease areas we're looking at, like polio, for example. But the one of the biggest
vision based.
Sorry,
is it vision based?
Yeah, computer vision based. Cool. So it's and you know, we've embedded it within the PocDoc app and the PocDoc platform. So we always had this vision that we would develop our own tests, but then also integrate other tests onto the platform, which we've done with COVID, and we're in discussions with some NGOs regarding polio testing and things like that, which would be great. But the biggest pushback that we got when we first started was that no one's gonna prick their finger. No one's gonna prick their finger. It's not gonna happen. Not gonna happen. No one's gonna do it.
All for COVID.
Yeah, exactly. And now, you know, you look at this thing, and people are, you know, swabbing themselves with toilet brushes. You know, I mean, it's not like with exactly, sticking things down their throat, and you know, we've come conceptually so far that we believe that sort of the interest and the responsibility that people have had to take in their own health, you know, will continue. And also that people, the one thing that's been clear about COVID and your ability to, your sort of, the quality of your outcome is how healthy you are. You know, that's pretty consistently, the healthier you are, the better chances you have of having a better outcome. It's not definitive, but you know, it's a pretty clear trend.
The post-COVID thing, like we said to each other we weren't going to dwell on COVID too much.
No, we can. I mean, I don't mind. It's kind of a thing, so we can talk about COVID.
But let's talk post-COVID. So, like that, because for me, this is where it's, because unbelievably, it sounds like beginning of the end. Like it's absolutely Herculean task with the vaccine rollout. Incredible that we even have vaccines. Incredible. Multiple vaccines tested. It's phenomenal. Like I can't. I by the way, I was one of the people starting to get a little bit negative about our capability to roll this out, and it's been incredible.
It's been like insane, world beating.
Yeah. So now what? Now we've got the most sort of daunting task of a year's worth of backlog to get through. All of that diagnostic test, all that testing that needs to be done, all those appointments that need to be arranged, all of that activity that needs to happen. That is the biggest challenge we have as a country. It's how are we going to start fixing people and checking up on people in the numbers that we need to and get back on top of it. I don't see a way, and like we either need to double the workforce or we need to start taking technology solutions like PocDoc and Infinity and a lot of others right now that can be helpful seriously.
Yes, and you know, and I think that they are. I mean, the Digital Health London Accelerator that we're on, and you've been on, and a number of the guests on the show have been on, I think is a sign of. And now you're on the NIA, the Innovation Accelerator. So I think that there's definitely the intent there. You know, there's really the intent, which is great. But I think you sort of highlighted it earlier. There seems to be a bit of a resistance, if that's the right way of putting it, of like, just because it works over here, it doesn't mean it's going to work for me. When actually, like a solution like Infinity will, you know, probably, you know, it probably will do, you know, because yes, the tasks might be different and the people doing the tasks are different, but your solution is sort of task neutral. You put whatever you want in there, fill the orange juice up, doesn't matter. Like it's more about the conceptual. Is there a process that is outdated and is analog, or we have a solution for that?
Yeah, as startups, I think this is the dirty secret. So startups try to find something really focused to work on and just do that one thing really, really well. And what we found was our one thing was uncomfortably larger than we wanted it to be. And it just turned out that you don't want to have 30 different task management solutions. You want one that works with all of the different within the ecosystem. And that's just a harder thing to build, but it's what the market and the end users and ultimately it's what patients need.
Yeah, and within within your sort of experience of working with the NHS and healthcare organizations, what are the, I know you said the frontline workers, they love the product, which I understand. What are the kind of obstacles or pushbacks that you get, if any, for expanding, for rollout, for uptake?
I think they're just all sort of like different flavors of the same no, which is it's never really a no, it's a not right now.
Okay.
It's timing. Again, it's timing. So everything we're saying makes a lot of sense to an organization, and no organization is perfect, and Infinity isn't perfect, right? So we're not, nobody's offering perfection, we're just offering improvement. And we're saying we can offer you improvement in all of these different areas in these ways. And they're saying, sometimes we're currently busy solving this problem over here, and that's got all of our attention right now. We'll speak again soon. That's the biggest challenge, is that you have to be saying the right thing at the right time to the right person, and that's not an easy thing to do when you've got hundreds of organizations all operating under the banner of the NHS, trying to improve services for patients and staff. You've just got to, it's like perfect storm again, or sort of like, we call it threading the needle. Is the best way to describe it. Is you've got to line up governance, you've got to line up clinical safety, you've got to line up a digital transformation program and improvement, the integration team and finances, and you've got to get an evaluation to build a business case. Like all of this has to be, like all of the circumstances have to be perfect for that to work. That's the biggest challenge, is threading the needle.
Cool. Well, look, on that note, I think it's time that we say thank you very much for coming on. It was a great discussion. Look, I love what you guys are doing. I wish you all the best. It sounds like it can make so much difference, not just to the hospital, but also to the patient. So, thanks for coming on, and thanks to everyone for listening.